Panic disorder. Group 2, Dennis Holt. Counseling 6310C02 Clinical Psychopathology. Group 2 members including Melissa Fuertes, Janice Cason, Teressa Foster, and Ivy Moses. Case background. Client profile and presenting concerns. Client's name, Dennis Holt. He's 31 years old, a successful insurance salesman. He's been divorced, and his personality traits include socially self-conscious and a highly driven individual. Dennis's primary diagnoses is panic disorder, agoraphobia, and generalized anxiety disorder. Key presenting issues. Dennis is seeking treatment for multiple anxiety-related conditions that significantly impact his daily functioning and quality of life. Symptom presentation and clinical manifestations. Panic attack symptoms. Infrequent but intense panic episodes. Physical symptoms include chest pressure, shortness of breath, and dizziness. Chronic physical and psychological symptoms. Dennis has persistent muscle tension, insomnia, gastrointestinal issues, and social anxiety in interpersonal situations. Behavioral avoidance patterns. Dennis avoids crowded and public places, avoids driving during rush hour traffic, and has significant lifestyle restrictions due to fear of panic attacks. Clinical history and treatment context. Onset and development. Dennis' first panic attack occurred at the age of 24. He was triggered during a high-pressure dinner situation and experienced a progressive worsening over 7 years leading to current presentation. Clinical significance. This case demonstrates the progressive nature of untreated panic disorder and the importance of comprehensive treatment addressing both psychological and behavioral components. Psychological impact. Increasing avoidance behaviors, relationship strain contributing to his divorce, social and occupational functioning affected despite professional success. Treatment readiness. Initially, Dennis was reluctant to seek professional help. He presented himself as confident and deflective during early therapy sessions. He eventually engaged in treatment process and previously was taking the medication trial Xanax, was discontinued due to side effects and dependency concerns. Case question number 1. Dennis met the diagnostic criteria for both panic disorder and generalized anxiety disorder. Did he, in fact, suffer from 2 separate disorders? What does your answer say about the issue of comorbidity in the current classification system? Despite Dennis meeting the diagnostic criteria for both panic disorder and generalized anxiety disorder according to the DSM-5, Dennis's behavior displays similar and overlapping symptoms that would indicate he is not suffering from 2 separate disorders, but instead a deeper manifestation of his anxiety. His symptoms, including persistent anxiety, physical symptoms, and avoidance patterns, appear to stem from a similar anxiety expressed in different ways. Although panic attacks are a main symptom of panic disorder, they also occur in conditions like PTSD, social anxiety disorder, and specific phobias. This highlights how Dennis's panic attacks are not exclusive to one diagnosis, but may appear in a broader sense. Comorbidity is the presence of 2 or more medical diseases in a patient. Dennis's symptoms and diagnoses according to the DSM-5 would indicate he does suffer from 2 separate disorders. However, his case highlights a concern with the current classification systems. When considering his overlapping symptoms would indicate a primary anxiety issue that is present in various expressions. Whether something counts as comorbidity or just a symptom depends on how we define the diagnoses. This suggests that the current classification system may reflect a process of overdiagnoses, where clients are diagnosed with multiple diseases for what may be a single underlying cause. Additionally, counselors must uphold the ethical responsibility of thorough and adequate assessments prior to a diagnosis to assist in reducing issues of comorbidity. Section E.5.A of the ACA Code of Ethics states counselors are responsible to provide accurate diagnoses based on information from assessments and personal interviews to determine proper treatment. Ultimately, Dennis's case highlights the importance of viewing the diagnosis process through a critical and ethical lens to best support the client. Case question number 2. What is the difference between the anxiety experienced by a person who is having a panic attack and a person who engages in excessive worrying? The greatest difference between anxiety experienced through panic attacks and through excessive worrying is intensity. Panic attacks tend to be more extreme and intense for the client in comparison to general anxiety. While both may create feelings of worry or discomfort, panic attacks may cause sudden and overwhelming sense of fear accompanied by physical symptoms. During a panic attack, it is common for individuals to fear death, losing control, or experiencing a mental breakdown. Additionally, panic attacks tend to occur more frequently than general anxiety. While both panic attacks and excessive worrying are forms of anxiety, they may display and impact the client in different ways. Case question number 3. During his first few meetings with his therapist, Dennis was self-conscious and defensive. How could his behavior have interfered with the development of the therapeutic relationship and with the initial assessment of his problems? What skills did the therapist need to use to avoid potential problems? Counseling interference of the therapeutic relationship and assessment could have resulted in a lack of trust. Through Dennis presenting an inauthentic version of himself and avoiding the topic, this can lead to a lack of trust from the therapist onto him as a client. The therapist may not believe what Dennis says, which can make for an inefficient therapeutic experience and poor therapeutic relationship. Behaviors being misunderstood and misinterpreted. In the case of Dennis draping his arm around the therapist, it was mentioned that the therapist was surprised at this overt behavior. This could have resulted in the therapist, whom was female, being uncomfortable to continue to work with him, causing him to be referred out, which may have impeded or discouraged Dennis from pursuing further services. Inefficient treatment plan. Dennis attempted to convince the therapist that he did not have an issue, and depending on his argument, it could have resulted in the therapeutic discussion continuing with the establishment of ineffective goals and treatments that would not benefit him towards progress. His presenting confidence of not having an issue may have led to premature termination as well. Misdiagnoses. Inaccurate and misleading information can lead to misdiagnoses and treatment. The possibility of Dennis presenting partial or half truths could have led to an inaccurate assessment and misdiagnoses. This would lead to the therapist suggesting treatment and possible medication that would not be addressing the real problem. Case question number 3 continued. Therapist skills to avoid potential problems included the therapist's ability to be patient. The therapist allowed Dennis time to grow comfortable with the idea of being vulnerable, which included enduring his attempts to convince her he did not have a problem and deflect conversation. The therapist was non-judgmental. The therapist did not judge or make assumptions about Dennis's behavior, but identified them as possible responses to his presenting issue. By creating a space for Dennis to be himself without fear of retribution or judgment, he was able to identify the sessions as a safe space, which gave him the courage to be more vulnerable and honest with his struggles. She was compassionate and understanding. When Dennis performed overt behavior in front of the other clients, the therapist was understanding and compassionate rather than offended and taken aback. The therapist recognized this as a sign of the severity of the presenting issue, and rather than make it about her, she extended forgiveness and grace, which may have served as a form of treatment itself. Part of Dennis's anxiety stemmed from apprehension of people not liking him. Empathy has been studied as being a positive contributor to positive therapeutic outcomes. Active listening. The therapist implemented active listening and acute observation of Dennis as he attempted to deflect from his presenting issue. His nervous speech and unpredictable mannerisms all provided hints and signs of an underlying issue. Case question number 4. Should a therapist actively encourage a patient to take medication that has been shown to be effective, even if the patient has strong objections to the use of pharmacological approach to treatment? No. The therapist is to implement cultural sensitivity. Therapists should refrain from impeding onto a client's convicted beliefs about the integration of medicine. Therapists are to practice cultural sensitivity and respect the multicultural sector of an individual, which may include personal, cultural, or religious beliefs against the use of medicine. Therapists are to seek out supporting literature that bridges the gap of pharmacological integration for these individuals. They are to benefit and utilize informed consent. Every assessment and informed consent discussion should address the possibility of the integration of medicine into treatment. Identifying where the client stands in the integration of medicine can help shape practice and treatment for the psychologist. However, as sessions proceed forward, the therapist should notify the client that the use of medication can still be evaluated and discussed at any point during a therapeutic journey. It will be best for the client to be the one to initiate those conversations about integrating medicine. Competence. Some mental health diagnoses, such as those that are psychopathological, may require the use of medication prior to experiencing progress in therapy. Diagnoses such as schizophrenia and bipolar consist of symptoms that may impede onto one's therapeutic progress. If the client refuses to take medicine that can stabilize their mental health symptoms, the therapist should consult with other professionals about resources for the client. Therapist has the right to terminate clients if their condition goes beyond the counselor's scope of competence or the client rejects the referrals. Case summary. Client overview. Dennis, a 31-year-old successful insurance salesman, diagnosed with panic disorder, agoraphobia, and general anxiety disorder. He was divorced, socially self-conscious, and highly driven. His background included his first panic attack being at the age of 24 during a high-pressure dinner, experiencing increasing avoidance and relationship strain, which led to his divorce, and he was reluctant to seek help initially and appeared confident and deflective in therapy. Symptoms included infrequent but intense panic attacks with physical symptoms such as chest pressure, shortness of breath, and dizziness. He experienced chronic muscle tension, insomnia, gastrointestinal issues, and social anxiety. He avoided crowded and public places and driving during rush hour. His treatment approach included cognitive behavioral therapy that focused on relaxation training, such as progressive muscle relaxation, cognitive restructuring to challenge catastrophic thinking, and in vivo exposure to feared situations, such as department stores and theater. He also tried medication, Xanax, but this was discontinued due to side effects and his fear of growing dependent on the substance. His outcome of treatment included significant reduction in anxiety and elimination of panic attacks. He improved his ability to cope with stress and engage socially. And there was residual gastrointestinal symptoms remained.